For the last day or so, we've been talking very specifically about NASH biomarkers and all the emerging science that's being done in that space. So I'm going to take a little bit of a different approach and zoom out a little bit and talk a little bit more about, from a regulatory perspective, specifically from a drug development perspective, how we can use biomarkers in big data and omic type studies to inform drug development, come up with more efficient clinical trials, improve the likelihood that a drug is going to make it onto the market, and ultimately improve patient care. So I'm an FDA employee. I don't have any conflicts of interest, but I would like to state that this presentation reflects my personal views and should not be construed to represent FDA's policies. So we've talked a lot about biomarker development over the last couple of days, and quite a bit of it's been specific to the FDA. So some of this has already been touched on, but I do want to highlight that there's several different work streams at the FDA that are involved in biomarker development. So we have several different things that we're working on, including we have public-private partnerships. So we work with several companies, several different members of the private sector on collaborative research initiatives, and these are a very important part of the work that we do. We also have internally funded research projects. So within the FDA, we have internally funded fellows and other individuals working on research projects, and biomarker development is a big part of this. The biomarker qualification program has been discussed quite a bit, but this is a formal program to garner CDER-wide acceptance of a biomarker within a specific context of use. Product review, so this is actually a big part of what my specific group does. This is a big part of what I spend my day doing, is actually when meeting packages and INDs are submitted, just like there's a toxicology reviewer and there's a clinical reviewer, our genomics group will actually, if there's a precision medicine type component to it or a biomarker-based enrichment, things of that sort, our group will actually review the IND package to make sure these things are being done appropriately and in an effective manner. Lastly, outreach, so safe harbor stakeholder meetings, different conferences, we get public input on how we can best utilize biomarkers. This slide is mostly just for references, but we do have many different FDA resources on biomarker development. I'd like to point out that for over 10 years now, we've been producing guidance on biomarker development, including guidance on pharmacogenomic data submissions that was produced back in 2005. There have been many other guidances produced along the way, and this continues to evolve as the science evolves. So we're currently working on a complementary diagnostic guidance. I'm not sure if everybody in the room is familiar with that term, but it's kind of a new category of biomarker. It doesn't quite fit the definition of a companion diagnostic that's essential for the safe and effective use of a drug, but it's something that we feel is useful in informing the risk-benefit of the drug. So this is a new category of biomarker, and we're currently working on guidance in that space. And the reason the FDA has focused so much on the use of biomarkers, and this talks specifically on omic data, is that we see many potential uses for this in the drug development space. So target validation is one that kind of gets overlooked sometimes, but and I'll talk about this in a little bit more detail on the next slide, but there's actually data out there that indicate that if you have a genetic linkage to the target that you're going after for a specific disease, that the drug is more likely to get approved. It can also inform anticipated toxicity, so you can have an idea of what toxicities you're going to see when you hit that target and determine if that's acceptable within the space that you're looking at. It can inform pharmacokinetics in a couple of different ways. So the typical thing that you think of me having a pharmacogenomics background is there's polymorphic drug metabolism and transport. And if somebody has, polymorphic drug metabolism, they might have toxic levels if you don't dose adjust. So that's one way that it can be used. But another way specifically for omic data, for microarrays and things of that sort, is you can actually use these studies to inform the effective dose. So get an idea of what kind of disease activity you're having within patients in your phase 2 trials. Use that to inform your dose selection for phase 3 and moving forward. Lastly, the efficacy and safety, or we could say benefit risk there just as well. So there's prognostic biomarkers that can inform that can enrich clinical trials or inform who's most likely to benefit in a clinical setting. Predictive biomarkers, so if you're developing a targeted therapy, which I'll talk a little bit about, using biomarkers to identify a specific subset of the population that might benefit more from the drug. And lastly, immunologic and idiosyncratic safety susceptibilities, so some of the HLA polymorphisms and other genetic polymorphisms has been shown to have some very bad toxicities associated with some drugs. So if you can identify those patients prospectively and prevent those individuals from getting the drug, you might be able to get something approved that otherwise would have too big of a safety issue. So all these are useful in drug development. The last couple of here can also be applied in the clinical setting in the form of potential companion or complementary diagnostics to inform treatment decisions. And so I alluded to this on the last slide, but it's been shown in a couple of different studies that biomarkers used in different ways can actually increase the likelihood that your drug is going to be approved. So this, on the left-hand side of the slide here, is a study, I believe this was done by AstraZeneca a few years ago, where they looked at their previous pipeline over the last few years and did a determination of what drove successes and failures. And they actually showed that within their phase 2 projects, if they had a genetic link between the target and the disease indication that they were going for, there was a 73% chance that that project passed through phase 2, whereas if they did not have that genetic link, there was only a 43% chance. They also looked at where they had efficacy biomarkers available at the start of the phase in phase 2A. I'm not sure how exactly they defined efficacy biomarkers, but presumably that's a marker of disease activity or a good pharmacodynamic biomarker. And they showed that if they had this in phase 2A, there was an 82% chance that the drug would make it through phase 2A, whereas if they did not have any kind of efficacy biomarker, it was only a 29% chance. On the right-hand side is a separate study where they looked at the probability of success with or without selection biomarkers. So this would be the predictive type biomarker in developing a targeted therapy as opposed to a more broad therapy. And they showed that in every phase, it increased the likelihood that they would make it through if they had a selection biomarker versus if they didn't. And on the far right-hand side of the slide, it results from phase 1 to approval in about a 3-fold increase in the chance that the drug's actually going to make it through approval versus not. So when biomarkers and genomics are incorporated into drug development, it can make a big difference in the likelihood of success. So biomarkers and omic data can also be used clinically. So I like to break the clinical use of biomarker testing down into a couple of different categories. There's a classical pharmacogenomics where we have polymorphic drug metabolism. Drugs that are metabolized by these enzymes are likely to require different doses or perhaps even they shouldn't be used in certain patient populations. On the right-hand side is more recently we've seen development of targeted therapy. So these are drugs that are developed for a specific molecular subset of disease. The mechanism of action is often directly linked to a molecular alteration. And there's numerous examples. I mean, this is much more common in the oncology space than other disease states, but we are starting to see this trickle into other diseases. In the bottom, ivacaftor is a drug for cystic fibrosis. Mepolizumab is for eosinophilic asthma. So we are starting to see these more targeted drug development programs as opposed to broad development programs across different disease states. So there's a summary of selected diagnostic tests on this slide, and what I want to get at here is the breadth of different types of tests that are available as companion and complementary diagnostics. So it started out in what's still probably the most common are very targeted tests. So vemurafenib is a melanoma drug. It's approved for patients with BRAF V600E mutations, so one very specific point mutation. But over the years, we've gotten a little bit more broad. So the EGFR tyrosine kinase inhibitors for non-small cell lung cancer. The diagnostics for these are able to detect specific EGFR exon 19 deletions as well as a specific exon 21 substitution mutation. There's also a number of other mutations that it detects where the drug is not actually approved that can inform whether or not it might be effective or resistance as well, but this is actually the indicated population is what's shown on the slide. Nivolumab and pembrolizumab are both anti-PD-1 drugs for non-small cell lung cancer. So these drugs both have PD-L1 protein diagnostics associated with their use. In the case of nivolumab, it's actually a complementary diagnostic, so it's informative but not necessary that you have that PD-L1 threshold of expression in order to get the drug. Whereas in the case of pembrolizumab, it actually is a companion diagnostic. So it depends on how you actually study your drug in the development program and how the data actually bears out what kind of diagnostic you end up needing to have. And lastly on the slide here is rucaparib and olaparib. These are approved for ovarian cancer patients that have deleterious mutations in BRCA1 or BRCA2. So here we're starting to get more towards an omic type approach. Actually, the rucaparib diagnostic is on a next generation sequencing platform. In this case, it's not specific mutations that we're looking at, but there's actually an algorithm to call it a deleterious mutation, and patients with any of these are eligible for the drug. So we are moving more towards this agnostic type approach in omic platforms, but it has taken us a while to get there. And the reason that I believe it's taken a while to move towards this approach is that as test development challenges increase, as test complexity increases, so do the development challenges. So as most of you know, and as my CDRH colleagues in the room can testify to, there's numerous challenges that are common to all diagnostic tests. So there's pre-analytical factors that need to be accounted for, analytical performance characteristics, the test needs to be reproducible. If it's a continuous biomarker, you need to establish cut points. And then you need to show clinical validity and clinical utility before it's going to be used clinically. So with the omic tests, we have all those challenges plus numerous other ones. So in the case of omic type tests, you usually have limited statistical power to use this agnostic approach to show an association, particularly in your early phase studies that have smaller patient populations. You also have massive data quantity to deal with, algorithm development, going the wrong way. Algorithm development becomes even more complex because you've got multiple analytes. You need to choose which ones make the final test for your, or final cut for your test. Defining the cut points is again an issue, but there's multiple different analytes involved, and then there can be weighting if it's a multi-SNP test, things of that sort. So all of this becomes much more complex when you increase in text complexity, but we are starting to move in this direction. As I keep doing that. In addition to the challenges with test development, there's also challenges associated with using omic tests in the clinical setting. So we have access to next generation technologies can be an issue, particularly across all different sites. Costs associated with testing, so reimbursement is very difficult to get for some of these tests. Interpretation of results, so whether or not the results are actionable or not, or which parts of the test result are actionable. Incidental findings, so if the test reports all data, there can be issues with reporting some of this back to patients and ethical issues and what the patients want in that regard. So all these things need to be considered from a clinical perspective. However, we are still moving in this direction because we see tremendous potential benefit for omic tests. So I've already talked a lot about the drug development advantages, so I'll go through these fairly quickly, but target validation, again, can be important and can increase the likelihood that the drug is going to get approved. Dose finding, it can explain variability. You can use stratified dosing if necessary, or you can use it for PD assessments. And lastly, patient selection for clinical trial enrollment, as well as identifying high-risk subsets. In the clinical realm, we've talked about a lot of these uses over the last couple of days, such as the risk assessment, diagnosis, prognosis, to inform the most appropriate treatment for individual patients, and dose selection as well. So there's tremendous potential benefit here. So we're starting to see omic strategies used more commonly in clinical trials. So this slide goes over several different examples. I'm not at liberty, obviously, to speak of specific examples we've seen at FDA, but these were actually just derived from searching clinicaltrials.gov for different biomarker strategies. And we're seeing useful implementation of these omic strategies in clinical trials. I mean, almost every trial has as the last exploratory endpoint that's listed. They list the looking through gene expression profile or something of that sort. But in these cases, they're using it for multiple different purposes, including there's a myeloma drug where they're looking at a 92 gene signature as a prognostic guide to guide treatment decisions. In lupus, there's an anti-interferon drug that's using an interferon gene signature actually as their primary endpoint in their phase 2 study to inform activity of the drug and dose. In ovarian cancer, I mentioned rucaparib is approved for patients with deleterious BRCA1 and BRCA2 mutations. However, they're actually looking at a more wide pathway approach, which is homologous recombination repair deficiency. So this can be a mutation in any drug in this specific DNA, in any gene in this specific DNA repair pathway. And they're trying to see if this is a better, more broad approach to identify patients that respond to their drug. The metastatic cancer, there's multiple different umbrella and basket trials that are using genomics and omic technologies for enrollment. And another SLE drug that's an anti-interferon therapy is actually looking at enriching and using predictive enrichment and only enrolling interferon signature high patients. So their hypothesis is that patients that have an activation of this pathway are going to respond better to their drug by knocking that pathway back down, and they're only enrolling this specific subset. So this is working its way into numerous different disease states at this point. I think a lot of these ideas are applicable to the NASH setting as well. We're also starting to see omics being implemented in clinical practice, and I think this is kind of the schematic that all of us would like to see, which is to incorporate omic testing into clinical practice, such as genomics, transcriptomics, and proteomics. You inform treatment decisions via diagnosis, therapy selection, and dose selection, and ultimately use this to improve meaningful patient outcomes. And there are actually a few selected FDA cleared or approved tests that have been approved for different uses in different disease states. So the MammaPrint is a breast cancer diagnostic test. It looks at the gene expression profile of 70 different genes in breast cancer tissue, and it's cleared to assess a patient's risk for distant metastases within 5 years. Cologuard, I've seen a lot of commercials for this lately, and you guys may have as well. It looks for epigenetic changes and mutational markers, as well as occult hemoglobin, and it's to indicate the presence of colorectal cancer. AlloMap is for heart transplantation patients, and it looks at RNA expression of 20 genes in PBMCs, and it can aid in identification of heart transplant recipients with stable allograft function that have a low probability of rejection. And lastly, on this slide, cystic fibrosis, there's a diagnostic test that detects 60 different mutations and 4 variants within the CFTR gene, and this is used for diagnosis as well as carrier testing and newborn screening. So we are starting to see that some of these tests work their way into the clinic and show great utility. So how do we capitalize these and continue to develop these tests? I think there's numerous different ways. One is high throughput exploration in early phase trials to inform later stages of drug development. So if you have a finding in the early phase clinical trials, you can start to stratify, start to enrich in your later phase trials and improve the likelihood that the drug's going to make it through. Data sharing to promote validation of findings from exploratory studies. So there's always the problem of needing more patients to validate your findings. I think that data sharing could definitely help with this. Well-planned and executed co-development strategies. So once you decide that you're going to go after a targeted therapy and have a subset of the population that you want to your drug to be approved for, you need to have, make sure that you're developing a diagnostic strategy and have a partner develop a diagnostic test. And lastly, access to next-generation technologies in the clinic so that we can capitalize on all of this. So to quickly summarize, the advanced tools, technology, and research that are currently being developed, coupled with innovative development programs and the development of reliable omic tests, will hopefully eventually lead to more approvals and better patient outcomes in this area. With that, I'll thank everybody, and are we holding questions until the end? Okay, thank you.